But anyway, like I had a discussion with David Bates, who's an MD, also kind of researching the impact of technology on healthcare and physicians and everything, and an internist, and he gave me some good statements. And he also made a comparison with the aviation industry, and he said that, he said, I have friends, who are pilots, and they say if there's a storm outside, you don't go flying, But in healthcare, that's exactly what we do. A patient can be in a terrible state, but you would still operate on him.
Well, again, so my brother is a pilot, and I, in a way, I've gotten interested into these industries, the HRO industries, the high reliability organizations. So I use not just aviation, but I use nuclear and I use oil and gas, because these industries have, when you look at the culture of safety in these industries and you compare that to healthcare, you realize what the problem is. And I've given a keynote lecture, on a conference in Australia. It's the CDIA conference. So today my lecture actually went on, and I used 5 reasons of why we have what I call the implementation gap, because the patient safety movement and the agenda started pretty much globally by 1999, because that was the time of the very famous report to Err is Human. And that report at that time said that in the U.S. alone, 44,000 to 98,000 Americans die from medical errors. Now, of course, we know that the number is much higher, but that report kind of pushed. It was like the spark that started the patient safety agenda in the U.S. and beyond. So fast forward 20 years later, we have done a very good job in bridging the knowledge gap. So in a way, we know what to do, but then the implementation gap is a problem. Let me give you one example. So the World Health Organization started in 2005 with something called the Global Patient Safety Challenges. So in 2005, there was the first Global Patient Safety Challenges, which was a very basic thing about hand hygiene. And then, the world, the international, the Hand Hygiene Day, the World Hand Hygiene Day is on May 5th. And, in a way, just to remember, it's on 5/5, so 5/5. So this is how you kind of remember washing your hands. And in 2008, there was also the surgical safety. In 2017, there was the medication, safety medication without harm. And I actually participated. I was part of that team that worked with the WHO on the third Global Patient Safety Challenge. But let's go to the first challenge, which is the hand hygiene. So it is clear that healthcare-associated infections is one of the biggest, one of the big problems of safety in healthcare. And evidence is clear that the number one cause of healthcare-associated infections is failure to comply with the hand hygiene. So basically not just washing your hands at these 5 moments that you should be washing your hands. Now, basically, even though that healthcare-associated infections kills hundreds of thousands of people, throughout the globe, and even though that we know that washing our hands is going to bring down the number very low, and vice versa, if we don't wash our hands, this leads to healthcare-associated infections, which could kill patients, and if it doesn't kill patients, it does all kinds of harm. In 2018, there was, when they looked at the compliance rate, the best country that was doing, kind of nationwide good compliance rate was around 80%, and it was Australia. But the average was around 40, not even making, up to 50%. So this is the implementation gap where we have, we know what to do, but we still don't do it. And there are 5 reasons for the implementation gap. One of them is the culture of safety. And this is where we kind of do the analogy between aviation and other industries, other high reliability industries versus safety versus healthcare. So safety in those industries is religion, and safety in healthcare is far from religion. So and the culture is very much dependent on the leadership. So I always kind of equate it with leadership. So if you have a good culture, it has to do with good leadership, and bad culture goes with lack thereof of good leadership. And then you've got the second is the lack of advocacy. So if you compare the global climate change movement with the global patient safety movement, both are very important. Why one is doing great and the other is not? Because the global climate change has a huge advocacy. So now everyone anywhere on the planet is aware of the global, the climate change is a problem, and we need to do something about it. Now, I think we can follow their footsteps and try to figure out what they did and how they managed to kind of make this issue, a mainstream issue. And I think this effort that you're doing with the documentary, and any effort to reach out to people beyond just your average small group that discusses patient safety, which is academia and some, people within quality and safety field, and to push it to mainstream, mainly public and mainstream clinicians, because many clinicians are actually not aware of that. And the third reason of the implementation gap is the information asymmetry. So what do I mean by that? When you have a clinician and a patient, the information gap, the amount of information that the clinician knows compared to the amount of information that the patient knows, the difference is huge. And that is a recipe for problem in any industry. So many industries actually have worked on trying to make sure that the customers are actually empowered with the right information, the whole idea of the data-driven decision-making and empowering the customers with the information. So this is a cry for patient and families empowerment, and the whole concept of co-production and how you can co-produce safe care and high-quality care at different levels, going from the co-design to the co-delivery to the co-assessment. And then the fourth one was about, which is very important actually also for medication safety. I mean, every one of what I said is important to medication safety, but the fourth one is the human factors engineering and the ergonomics. So the whole idea of the concept of resilience. And again, high reliability industries have integrated human factors and ergonomics into every aspect of their day-to-day workings. Whereas in healthcare, it is still kind of sporadic and still something that we're experimenting with. So human factors, just for anyone who's watching or listening, is the interface between the human interface or the human technology interface. So, what do I mean by that? If a physician is talking to a patient, if a nurse is talking to a patient, that interaction if we're not careful about how we are conducting this communication, there can be communication failure, and that could result in misunderstandings on both sides, and that could result in major harm and maybe even patients dying from errors. So how can we integrate that into also the day-to-day workings, as well as, dealing with electronic health records and computerized physician order entries and what have you, to make sure that interface is also resilient, and making sure that the fact that we are humans and we make mistakes, how can we make sure that we make that interaction less liable to errors and error proof, or at least minimizing, making sure that we can catch errors early on without causing harm. So even if we make errors, because we as human beings will make errors, how to make sure that we're not making harm. And the fifth one is, again, a very important one, the fact that currently we're not even using the same taxonomy. So even though that we have ICD, which is International Classification of Diseases, now we have 10 and we're going to 11, and we've had it for decades, we don't have ICAE, which is International Classification of Adverse Events. So within the same country, maybe within the same city, you can have two hospitals, and everyone is kind of calling the adverse events with different classifications. And if we were to actually have a common platform, starting from citywide, nationwide, regional-wide, and global-wide, if we have to have a global learning platform where we share these learning experiences, then the precursor for that is to make sure that we're using the same taxonomy. So we're calling an origin, and apple. So these are the five reasons, I would say, the five causes of the implementation gap. And we can talk about safety for the next decade, and we've been talking about it for decades. I think if we don't address these five areas, we're going to be here 5 years, 10 years from now with the same problem. And again, we've talked about the magnitude of harm is major. So I'll stop here because I've been talking a lot.
That's why you're here. If we go to the beginning, why is patient safety your passion? Let's start there.
Well, I joined healthcare to help people, and again, I'm looking at it at my kind of personal level. And I mentioned that my brother is a pilot, so we're the same, family, same, siblings. He works in aviation. I work in healthcare. Somehow, and I believe that, to err is human, because we're human beings. We're not perfect. We will make mistakes because we're just not perfect. Somehow, he's in an industry that when he makes mistakes, he doesn't end up crashing the airplane that he flies, and because he was put in an industry that is resilient, in an industry that is basically viewing safety as something that is an aspiration to aim for every single day, every minute. And that's why aviation is the safest industry on the planet. Now, I'm the same, almost genetic material. And I work in an industry, but the industry has many challenges where my errors that I make as a human being actually end up harming patients. And unfortunately, as a practicing surgeon and as a practicing clinician, I ended up having patients that were harmed because of the fact that these errors that I made as an individual, the system itself still did not have the way to kind of figure out that error, figure out, the oversight that I had, and deal with it before harming patients. So that's on one end. On another end, I mean, public service to me is very, admirable. And, since I mentioned genomics and genetics, so in 2003, the human genome was sequenced for the first time, and we realized that actually you and I and the 7 billion plus out there in the planet share more than 99% of our human genome. So we're almost identical twins. And so what makes us different is less than 1%. Just keep that in mind. And somehow we focus on that less than 1% rather than embracing the 99%. And to me, I view myself as a global citizen. This is a global challenge. So to me, a global problem requires global solutions. So you from where are you filming from? Slovenia? So you're filming from Slovenia. I'm here in Saudi, and I'm part of the Global Patient Safety Network. I think to me, there's nothing more meaningful and fun than having us trying to figure out a way to, prevent harm and reach zero harm. So that's another kind of passion of mine, that saving one life is actually something big. How about if we could save millions of lives? So, nothing beats that.
Yeah. If we try to go to the beginning of your medical career, do you by any chance remember, what your expectations were, and maybe how that perception or that hope changed over time, if it changed?
Well, when I decided to go to med school when I was in high school, and at that time, and don't ask me why, I wanted to become an ophthalmologist and an eye doctor, and then I joined healthcare med school in Saudi is 7 years, so 6 years straight from high school, and then a year of internship. So throughout my first three years, I moved towards, maybe I would just want to be an internist. And then between the transition from basic years into clinical years, it was just a coincidence that I went and I did surgical summer training in one of the hospitals, and then I decided that I wanted to become a surgeon. Then the year after, I actually have done a summer training at Columbus, Ohio in the States. And I worked with the transplant team there, and I decided that not only I want to become a surgeon, but I want to become a transplant surgeon. And then afterwards, I've done my residency in Nova Scotia, Canada, and then I did my transplant and hepatobiliary fellowship at Mount Sinai in New York City. And basically, I became a transplant and a liver surgeon, but my interest in healthcare grew more from just the micro aspect of it. So there's the micro, meso, and macro aspect. So the micro is at the bedside, the interaction between patients and physicians, and then the meso is at the healthcare facility side, and then basically the macro is at the kind of the national and the global side. So I became interested in quality and patient safety, and I became interested in the system aspect of healthcare, because it's fascinating. It's Healthcare is the most complex system created by man, and it has probably it's like 18, 20 industries in one industry. Talking about medication safety. I mean, we can talk about what the number of industries that are involved in medications. The academia side, the clinical side, the biotechnology, and human factors, and on and on and on. And how can you bring all that in to work in harmony towards a common goal? So it is a fascinating. So that's kind of been my work in progress or development. So I continue to work as part-time clinician, but I'm very much dedicated also to my life's mission. I think I mentioned to you before that it's to be a tool for healthcare systems transformation. So because I think it is healthcare systems are still have an opportunity to be transformed, and transforming healthcare systems means saving millions of lives, means saving billions of money that can be used to do more good, and actually also transforming healthcare systems can be a tool of peace promotion. When we're living in time where there are forces of pulling us apart and forces are bringing us together, the work in healthcare also has that aspect to me. So these are the kind of the different ways of why I like what I do.
So you never were kind of disappointed by healthcare? Because sometimes I'm wondering, sometimes students of medicine get disillusioned by the intense workload that they get, the stress, the hours, the mistakes that they see. So I don't know, did you ever see any medication management related errors, and what were the consequences of those? Do you have any personal experiences about that?
Yeah, well, I'll tell you about some personal experiences, and then I tell you from my own practice, and then I'll tell you also about some problems that I'm aware of from other hospitals. So at my own practice, first of all, I love what I do, and I love all the different aspects of it. So I want to continue to practice as a clinician, but I'm not practicing full time. But I also like to contribute to the different aspects of healthcare. So I think you really have to love what you do. And I remember one of the interviews with Steve Jobs where he said, you really have to love what you do, because otherwise, it's very hard. Because everything, whatever it is, healthcare or anything else, has difficulties. So if you really don't love it, then when the challenges come in, and every sector, every work has challenges, then it becomes very difficult. So I love what I do, and just going back to the stories. This was very, very close. So a friend of mine's mother was a patient of mine, and she had an abdominal problem and required to have a piece of her large bowel, a piece of her colon removed, and I did that surgery, and she was in her 70s, I believe, 70s, maybe late 70s, early 80s, and she was in polypharmacy, and one of the medications that she was on was L-thyroxine. So it's basically a hormone for patients that have low thyroid, for people that are just not familiar with it. And basically, her dose was 25 micrograms of L-thyroxine. And at that time, the hospital that I worked in, the medications were actually brought in manually. So one of the junior doctors rewrote, sometimes when you have so many medications, it becomes a mess, so you have to kind of rewrite it. So he rewrote the medications, and he just added 10. So rather than it's 25, it became 250. And a patient that old, when you're multiplying the medication by a factor of 10, could have gone into basically heart failure with that dose. Who recognized the error? The son, my friend. So it was like it was a near miss that she almost got the wrong dose, and it was the Swiss cheese model where at the very end, thank God, it was recognized, and that was a very tough one to deal with, and hopefully it was avoided. Now, at some of the other stories, because I work also, I have an advisory work with our healthcare accreditation organization in Saudi, so we have information about different hospitals, and this was, I don't know, 7-8 years ago. So one of the hospitals had a patient, young patient, I think 40 years of age, who had laparoscopic cholecystectomy. Basically, he had his whole gallbladder removed with the laparoscope, and everything went perfectly well from a surgical perspective. And he was in the recovery room, and next to him was an intubated, ventilated patient on a muscle relaxant. He was on brachyonium. And the nurse was going on her way to give that patient the brachyonium. She got distracted, so rather than giving the patient who's intubated, ventilated the brachyonium, she ended up giving the perfectly healthy 40 years of age patient who had his gallbladder removed, a day surgery, brachyonium. The bad part of the story is that patient ended up actually dying. And you could just imagine how horrible his death was, because you could, when you can't even call for help because you're paralyzed. I don't know if you saw the movie Awake. It was like about a decade ago or so. So some patients, and this is a phenomenon that is known, where some patients under general anesthesia, they sometimes their anesthetic, without the anesthesiologist knowing, becomes a bit light, so they wake up, and but they're paralyzed because they're also under general anesthesia, so they can't even move, and some patients actually have PTSD, post-traumatic stress disorders, because you're awake but you can't move. So again, that muscle relaxant problem is another one. Now, the one that is also, I think it's worth mentioning, is the Dennis Quaid story in 2007 at Cedars-Sinai, where he had twin babies, and they were giving the wrong dose of heparin, a blood thinner, 1,000 times the wrong dose, and not only once but twice. And thank God that they basically survived. But you can imagine the ordeal and the horror that both parents went through to deal with such a problem. And again, this is a story that is a public record, so we're not revealing any secrets here. But the thing is, if this could happen to Dennis Quaid's twins at Cedars-Sinai, it could basically happen to anyone. So I think that is in a way an indication that we still have problems, and how can we listen to these stories with the mindset that is focused on eliminating that preventable harm as we move forward.
It's Well, what can I say? I didn't expect so many horror stories, although I was aware of mistakes happening and fatal mistakes happening. But what seems to be an optimistic outlook is the fact that in terms of medication management with technologies and with electronic prescribing, things like illegible prescriptions are no longer a problem. And there's new decision support systems that are going in the direction of helping prescribers detect overdoses, detect if there's a clash between two medications. So from this perspective, how do you see that medication-related patient safety is improving with technology?
I want to say I'm cautiously optimistic, and I'll tell you why. Healthcare is developing at a speed, just light speed, and the new, medications that are coming up. There's actually they looked into the medical data. And the time it would take for medical data to double. So in 1970, I think it was estimated that it would take, 20 years, 30 years for the medical data to double. In 2018, that number came down to 73 days. So every 73 days, the medical data doubled. And what I'm trying to say is with the explosion of this new medications, the biologics, the monoclonal antibodies, you name it. It is still, it's a very good technology to have. I think what closes the circle here is the patient. So, and the patient and the family. And I'll tell you why, because let's say that we're prescribing, a paracetamol for a patient, and you've got the best electronic health records, and you've got the best the computerized physician order entry, and everything goes well. But then at the point between the dispensing, the transcription and the dispensing of the medication, you could still have an overworked, understaffed unit where an individual nurse just makes the mistake. Now, who would be helping us to make sure that we really transform the safety is the patient and family. Because if the patient and family knows that, we're not trying to make patients and families clinicians. That's not what I'm saying here. But we want to make sure that patients and families are really integral part of the team. So if the patient knows that, so my treating physician is X, my nurse for this shift is X. I have 5, 6 medications. You could be more interested in their names, but even if not, when you're having the medication coming in, you want to remind also the nurse, okay, is that the time for my medication? Maybe, that pill looks different. What is the name? So trying to educate, empower the patients and their families with the right information. I mean, think about mothers with in pediatric wards. Who would be the better kind of help to make sure that harm doesn't happen to those kids, rather than the mothers who are very much, are very keen on making sure that their kids are not harmed. When you listen to many of the stories, and again, I left so many stories untold. Some of them are public records. I talked about Helen Haskell, who's done a great work in patient safety and in for patient safety with the WHO. She's a great advocate for that. Listen to her story about how her son was, I think, 13 or 14, died from a medication error. and because he was giving a dose of an adult, and a non-steroidal anti-inflammatory dose of an adult, ended up having a perforated duodenal ulcer. And you talk to Helen, who's a good friend, and again, she mentions it in the video in YouTube. It's YouTube. You can just Google it. And she has been saying that there's something wrong. There's something wrong, and every time she was just brushed aside. So imagine if we actually integrate patients and families in the co-delivery piece. So it's like another check, the final check. Imagine what would happen. Now, I'm not saying that technology is not going to help us. I mean, there is also the technology that tells us even the compliance with medications at home. Like the technology is getting there. But what I'm saying is, without bringing these two key stakeholders together, so we've done a lot of work on the provider side, but I think if we bring patients and families and empower them, we don't want them to become, very, another doctors or nurses. We just want them to be educated about their own disease, about the treatment plan. So if there's another medication, you could just ask. So an overworked nurse who's basically just distracted does not end up harming the patient or the family member, because we have someone who's that part of the team. So I think that's what I'm trying to say. I think the technology is great. I think with time and getting also IoT, the Internet of Things, and AI, many things would help us. But that ergonomics, that human factors, engineering piece, I think it would very much benefit from empowering patients and families.
I still want to stick just with technology a little bit. Great point, by the way, and quite an insightful one as well. But just looking at technology, and now if I consider what exists in order to prevent medication errors, is the concept of the closed-loop medications. So in essence, the prescriber prescribes something with the help of the electronic system, gets warned if a dose is too high, then that receipt or that prescription goes into the pharmacy. There's a robotic system that dispenses the right dose of the medication, and then it's taken in a cabinet to the ward, and the nurse needs to scan with the barcode the patient and the medication, just to make sure that the right drug goes to the right patient. What are your experiences with those kinds of systems? Do you see them in your practice? And to which extent, perhaps, is the cost of this solution making the closed-loop medication management unattainable for healthcare institutions?
I think
I'm just trying to think, because we really have a lot of technology by today. So one of my main questions is that, is this technology not being used? Is it too expensive? What's the problem that we're not exploring the potential of it?
I think robotics are again, as you mentioned, I think have and continues to actually do a great job of improving medication safety. As you alluded to, I think cost is going to be a limiting factor here for many, not even just low and middle income countries, but even high income countries, because healthcare is becoming more and more expensive. So I think if that technology exists, we need to think about it in the entire system that has that leadership that is very much focused on zero harm and promoting the safety culture and the just culture. I think so that's one aspect. Getting that. Having it's so what I'm trying to say is, like, these are different pillars that have to work in harmony together. in the presence of all these different pillars, empowered patients and families, very much committed leadership and safety culture, definitely technology, if the financial means are there to get it, is going to be helpful. I think my goal, and I've always been thinking about this even at low middle income country settings, where on an annual basis, 2.6 million people die from basically unsafe care, and there are 134 million adverse events in low middle income countries. It is, we have to kind of think of how these solutions would be helpful, would be helping us. Many of these countries don't even have still the means to roll out and implement electronic health records because of the cost factor. So I think technology is great. Now, who knows? Maybe with time, we will see a drop in the in some of these technologies, and which would make it more available for low income setting, as well as not just high income setting.
Do you think that could change if the patient safety issue became a priority? Because, for example, we do see in the NHS that the country is highly investing in the adoption of technologies to improve patient safety, to improve medication safety. At the same time, every time you talk about medication-related errors, there's estimates or studies showing the financial cost of these. So according to WHO, the cost of medication-related harm is $42 billion every year. And in the NHS, supposedly the cost of errors related to medications is estimated at £98 million. So on the one hand, we've got these huge estimates about the costs of medication-related errors. So why is the investment part that would actually decrease these costs such a problem?
Well, again, that's a very good question, and I think that was one of the motives behind us last year pushing to put patient safety on the G20 agenda during the Saudi presidency, and we actually commissioned a study by the OECD to look into the economics of patient safety, and again, it showed that more than 13% of the health expenditure in the healthcare system is wasted due to unsafe care. I mean, you could look up the report. The OECD report is actually out there in the public. That's the second OECD report, because there's another one also in 2017 that was commissioned by Germany. Now this is not to mention the indirect cost and the opportunity cost. So the opportunity cost is actually calculated and estimated to be in the trillions, because when a country has, when a citizen is harmed, not only that the country actually loses twice, because not only that you have to treat them, you also lost their contribution and productivity to the GDP. So in a way, yes, I totally agree with you that if patient safety becomes on the radar of decision makers, to the point of linking it with the economy and the sustainability of healthcare systems, then we would probably see more investment in these technologies. I mean, currently the G20 countries alone have spent, I don't know how many trillions of dollars on COVID alone. So if you grab the attention of decision makers and policymakers to the challenges of patient safety and medication safety, then that would be one of the strategies to try to get more funding for this.
I just have one more question for you. So you are certified in the US, in Canada, you're now working in the UAE. Can you make any comparisons between the systems, or did you work in all three countries? And what kind of differences did you see, if there's anything that's relevant to mention?
I have, so I'm Canadian and American board certified. So I practiced in Nova Scotia, Canada for a number of years as a surgical resident. And I also did my transplant and hepatobiliary fellowship at Mount Sinai Medical Center in New York City. And I've been working for the past more than 10 years in Saudi Arabia at different hospitals, both academic medical centers as well as government hospitals as well as private hospitals. So I've been in different healthcare systems, and it is very much clear to me that the challenges of patient safety and medication safety has nothing to do with geography alone. Because in a country like the US and Canada, the third leading cause of death after heart disease and cancer is medical errors. In a country like the UK, 150 preventable death happens every week. These are advanced and top healthcare systems. And, I talked about the 134 million adverse events that takes place in low middle income countries, which is causing 2.6 million deaths in low middle income countries. So in a way, this is not a high income country's problem, nor low or middle income country's problem. This is a healthcare system problem. It's a global problem. And the way to deal with it is to deal with the causes of why we are where we are, which I mentioned at the beginning. Things around the safety, culture, things around the human factors and ergonomics, empowering patients and families, and using common taxonomy and the advocacy piece. We really have to keep pushing the envelope and making sure that this issue becomes mainstream. These numbers are just, people are become aware of those. And if people in many countries realize that healthcare is not as safe as we think it is, and if people realize that there are potential harms, then they're going to push those healthcare systems towards finding a solution. And if there's a will, there's a way. So I think, that would be my thinking of how to deal with this. It requires these kind of concerted global efforts, technology, leadership, empowering patients and families, getting us to work together. And I think we can very much in our lifetime see transformation of the safety of medications and patient safety in general.
One more question. We talked a lot about problems. We talked about technology, which almost turned out to sound as a very minor factor in the whole story. But just to kind of try to find good practices as well, is there anything that you can mention that you saw that worked really well in improving medication-related patient safety?
Again, I know we're talking about the culture, but I truly believe, and the record is out there. Places like Intermountain Medical Center in in the U.S., places like Cleveland Clinic. These are some of the places and stories that I'm aware of where these different pillars or pieces of the puzzle, if you will, but it starts with the right leadership. You really have to have the leadership in the healthcare center, in the medical center, in the hospital, in the healthcare system, to say that safety is a priority for us, and zero harm is our goal, because all these other industries that we've mentioned, that was the beginning. It's like creating that urgency that we really have to have zero harm. 10% is unacceptable. So I think to have that leadership to really push the agenda forward, that's going to then be coupled with having the right technology that would help us. And I would say the right processes. So it's not just the technology, because the technology will be integrated into processes. And depending on your financial means, you figure out whatever processes that would work for you. Bring the clinician and patients and families to work together to co-produce this high quality and safe care. Empower patients and families. Make sure that we listen to them more. I think if we manage to do that, in addition to having kind of incentives for research and innovation, and innovation on how we can actually push the envelope to improve safety, because as we're doing that, we also need to keep pushing the agenda of innovation. And I think with time, these different components, I think, would help us to reach towards zero harm, which I think should be the goal of any healthcare system, any hospital, and any patients and families.
I want to stop with the leadership part for a little bit longer, and that's going to be the last question, I think. But I would assume that every healthcare leader is aware that patient safety is important. And if nothing else, especially in the US, you want to avoid mistakes and patient harms due to the litigation issues. So what is it about leaders that are successful in driving the patient safety agenda? Are they charismatic? Do they have a specific approach towards the topic? Because I'm always kind of fascinated about things that seem straightforward, but are actually really difficult to master. Things like how to manage expectations, how to get buy-in of people to adopt technologies. I can list the things that you need to do, but how to actually do it is kind of like a secret sauce that is almost impossible to describe sometimes. So from that perspective, I'm wondering, why are those leaders different than other leaders that are not successful in getting the culture to change?
So I would break it down into the will and skill. So you want to have the will and you want to have the skill. And I think I don't want to say that people, leaders that are not doing well in safety are intentionally ignoring that. It's just they're not putting it as at the top. And I think if you, in a way, if you, there's now this, it used to be the triple aim and now it's the quadruple aim. So the quadruple aim should be the direction of any healthcare system, which is better health for the population at large, and then better care and experience of patients throughout the episode of care. And the third one is doing it at a lower cost. And the fourth one is satisfied and safe healthcare workers. So if you put that as your true north, and in that aspect, putting patient at the basic minimum, putting patient safety as the basic minimum, which is the having preventable harm or zero harm, then that would be, in my mind, the will, having the will to do it. And if you have the will to do it, then the skill comes in, and everyone does things differently. I mean, there are tested and tried aspects, but part of the skill of doing it is the processes, the technologies, the pathways, etc. But keep in mind, we've been trying at this. I mean, even people that are very much committed to improving patient safety, they've been doing most of that. And I think the element that was left behind is empowering patients and families. So the co-production piece, I think if we do all the good practices and improve the culture, etc., and bring patients and families. So the definition of patient safety is the absence of harm. And it is very difficult to apply patient safety as kind of a one-size-fits-all. So we really have to personalize it. And the way we personalize it is we personalize it along the patient's conditions, either within the inpatient setting or the outpatient setting. And we empower patients and families with the right information so, they can help us help them. And if we do that, I think then we would see the transformation. So it's the will and skill, but the thing that would bring this forward is to personalize safety and make sure that we empower patients and families and we co-produce safe and high quality care.
Yeah, it's a really nice point and an important one, and it just got me thinking how I'm dealing with these issues. I'm thinking about this a lot, but when I'm in the patient role, I would still have this confidence that the healthcare system is safe and the people that take care of me know better than I do. So, as patients, I think that's the catch. How do you turn on the skepticism or carefulness switch when you're in an environment that you basically trust completely because it has such an authority in the perception of patients?
I think trusting is important, and I think it's very important to keep that trust. But I'm telling you, as a clinician who's been in healthcare for some time, the only way to really do this, we can't do it alone from the provider side for every patient. I mean, we know that every patient and families do not want to be harmed, right? And they want to be, they want to be treated, and they want to be treated with respect. So, patient experience, patient care, patient safety. So the only thing that we need to do is to really give them the tools and the means to be, helpful team members. So that mindset has to change from them to really be just passive participants. That doesn't work. I've been saying this for a long time, and I'm very happy to have a conversation with anyone who would disagree with me. Treating patients as passive recipients of care does not work. So we can do whatever we can do with the technology. We can do everything. The only way that we can make sure that this individual in this hospitalization is treated well and leaves with no harm is to make sure that we engage them and we engage their families and tell them how they can help us help them. I think that's the only thing. So it's not about making people lose trust or making people afraid. It's just to make sure that to tell them that that's the missing piece, and whatever we can do unless we bring that missing piece together, we're not going to be able to really reach zero harm for every patient. I mean, that's the thing. You can have one or two patients. The goal is you want to have it for every patient. So imagine if we, at the beginning of the care, we co-produce even, we ask patients and families, so what are your goals of the treatment? Because patients and families have goals of treatment. Clinicians have goals of treatment that are more clinical. If someone wants to have a knee replacement, their goals of treatment is maybe to walk again or to do whatever. The surgeon's goal is certain things that have to do with the surgery itself. So how can we have like a document that put these goals of treatment together, and then to say, okay, for us to reach that goal, for you to have these 3, 4, 5 days of admission and then go home safely and go to almost the goal of the treatment that we just discussed together, here's what we're going to do, and here's what we want you to do. And it could be as simple as, if you have any questions, please, and concerns, just let us know. These are the things to keep your eye on. So we don't want to overwhelm patients and families because they're already overwhelmed, but we will not be able to reach zero harm without empowering patients and families.